Hello everyone and welcome to this new video of Internal Medicine Board Review questions. This is part 7 and it is related to pharmacology. I'm Dr. Mohammed Tinawi. I'm board certified in internal medicine and nephrology. I practice in Northwest Indiana. This is my book on fluids and electrolytes. You can find it on Amazon. Please follow the link below. Let's get started. Question number 1. A 55-year-old man presents to the renal clinic for a routine follow-up. The patient has stage 4 chronic kidney disease due to diabetic nephropathy. He is complaining of mild fatigue. Labs: hemoglobin 10.7, creatinine elevated at 2.6, blood urea nitrogen 42, estimated GFR 28 ml per minute per 1.73 meters squared, potassium 4.8, CO2, serum CO2 or bicarbonate at 23. Fasting blood sugar is 176 milligram per deciliter. Hemoglobin A1C is elevated at 9.2%. The patient is on glimepiride 2 milligrams daily for the management of his type 2 diabetes mellitus. Now, what is the next step in his diabetes management? What is the best answer? Is it A, increase glimepiride to 4 milligrams daily, B, add metformin 1000 milligrams twice daily, C, add insulin glargine or Lantus at bedtime, and D, or is it D, add sitagliptin 25 milligrams daily. So please pause the video for a second, think about these different answers, because the correct answer will be on the very next slide. The correct answer is add insulin glargine or Lantus insulin at bedtime. Why is that? Now, this patient has stage 4 chronic kidney disease. If you increase glimepiride from 2 milligrams to 4 milligrams, number one, you're unlikely to reduce the hemoglobin A1C to target, which is 7%. You're just more likely to cause hypoglycemia. Answer B, metformin 1000 milligrams twice daily is a very high dose, and it is inappropriate to start in someone with chronic kidney disease stage 4. If you look at the table that we have here on the right side of the slide, if the estimated GFR is above 60, you can start metformin full dose, no problem. Once you have someone with stage 3A chronic kidney disease, so GFR 45 and above, the maximum dose is 2000 milligrams, so 1000 twice a day. Now, once they're stage 3B chronic kidney disease, then you cannot go higher than 1000 milligrams, meaning 500 milligrams twice a day. And if someone is stage 4, 5, or dialysis, you do not use metformin due to the risk of lactic acidosis. Granted that it is very rare, but when it happens, mortality is 50%, so you don't want that. Okay, so now this is what we've learned so far. Someone with chronic kidney disease, advanced stage 4 or 5 or dialysis, we don't want to use much sulfonylurea. It's better not to use them. And if we do use them, we have to use a low dose. We don't want to use a high dose metformin. And once we are at stage 4 or higher, we're not going to use any metformin. If someone is on metformin, we have to stop it. Insulin will get us there, okay? We can adjust the dose and we can reach our hemoglobin A1C target. Sitagliptin 25 milligrams is appropriate, but it's not going to lower hemoglobin A1C by 2.2%. So you can add it on, but it's not the best answer, and we're always looking for the best answer. Okay, now question number 2. So here, what actually happened to this patient? So I said ideally you want to start this patient on insulin, but that didn't happen. The patient declined insulin. Many people don't want to use needles. In this case, glimepiride was discontinued, and he was started by his primary care doctor on glyburide or diabeta, 10 milligrams orally twice a day. Now, after 1 week, he presented to the emergency department with hypoglycemic symptoms. His blood sugar was 34 milligrams per deciliter. What should we do next? A, discontinue glyburide and give intravenous dextrose in the emergency room. Once blood sugar is above 100 milligrams per deciliter, discharge the patient home off glyburide. Or is it option B, reduce the dose of glyburide to 2.5 milligrams twice daily and then discharge home after IV dextrose is given? Is it option C, discontinue glyburide, restart the patient back on glimepiride 2 milligrams daily, and discharge home after intravenous dextrose is given? Or is it option D, admit the patient to the hospital for observation after IV dextrose administration in the emergency room, avoid sulfonylurea in this patient altogether? So give yourself a second to look over these different options, and the correct answer is on the next slide. The correct answer is admit the patient for observation after intravenous dextrose administration, avoid sulfonylurea medications. So like I said, someone with stage 4, 5, or dialysis, you should not preferably use any sulfonylurea. Now, the worst one you can use is glyburide. This is really infamous for causing severe hypoglycemia. I've seen many instances of sulfonylurea-induced hypoglycemia in patients with advanced chronic kidney disease. You really have to admit the patient to the hospital. Hypoglycemia can last for hours or even days. Usually you give intravenous dextrose like D50 in the emergency department, then you start them on D10 until they're stabilized. So again, don't use sulfonylurea if you can, and if you're going to use something, use maybe low-dose glimepiride. Glyburide is a definite no-no. And so reducing the dose is wrong, and sending the patient home after just one ampule of D50 is also wrong, because you can have hypoglycemia later on. Okay, so we've learned that, and now we'll move to question number 3. 57-year-old woman presents with severe lower urinary tract symptoms. She has stage 4 chronic kidney disease due to diabetic nephropathy. Labs hemoglobin 10.2, creatinine 2.8, BUN is 52, estimated GFR is 19, potassium 5.2, serum CO2 or bicarbonate is 19. Urine culture showed pan-sensitive E. coli, E. coli sensitive to all antibiotics. And we don't have history of allergies to any antibiotics. What is the next step in management? A, observation. Start antibiotics only if the patient develops fever or flank pain. B, give sulfamethoxazole, trimethoprim, or Bactrim. C, give cephalexin. D, give nitrofurantoin. So think about these different options. Pause the slide if you wish. The correct answer is C, cephalexin. Why is that? Option A, observation, is inappropriate. The patient has severe symptoms, and she has a confirmed urinary tract infection. It is very appropriate, and there's absolutely no need to treat colonization. Older patients with no symptoms. This patient is 57, so she's not that old. But at any rate, observation is not appropriate because of the symptoms. Now, option B, Bactrim, is inappropriate. This patient has stage 4 chronic kidney disease. Her potassium is already elevated. And what Bactrim does, actually what the trimethoprim does, and pentamidine does that also, it blocks the epithelial sodium channel. Sodium this way will not go in, therefore potassium will not go out, and that will cause hyperkalemia. She's already hyperkalemic, and if you start Bactrim in a couple of days, the patient can come in with a high potassium, 7, for example, or worse, a cardiac arrest. So that's not a good option. Cephalexin is a fine option, especially the patient is sensitive, the urine culture, the E. coli is sensitive to cephalexin. Nitrofurantoin is not appropriate for patients with chronic kidney disease. You can get toxicity, neurotoxicity. So anyone with the GFR below 60, avoid nitrofurantoin. Okay, so we've learned about Bactrim or trimethoprim blocking the epithelial sodium channel and worsening hyperkalemia. Question number 4. Here we have a 77-year-old woman presenting with fatigue, nausea, dizziness, and shortness of breath. She has stage 3 chronic kidney disease due to hypertensive nephrosclerosis. Past medical history is significant for heart failure with reduced ejection fraction or chronic systolic heart failure. Medications: lisinopril, atorvastatin, digoxin 0.125 milligrams daily, clarithromycin 500 milligrams twice daily. That was started 4 days ago for upper respiratory tract symptoms. On exam, blood pressure was 118/62, heart rate was 51, and the rhythm was regular. ECG shows sinus bradycardia. Laboratory evaluation: creatinine was 1.6, BUN 32, estimated GFR is 33, potassium was 4.8, serum CO2 23. Digoxin level was elevated at 3.1 nanogram per milliliter. So digoxin obviously was discontinued and the patient was admitted to a telemetry unit. What is the next best step in management? A, observation. B, give digoxin specific antibody fragments or digibind. C, discontinuation of clarithromycin in addition to observation. Or D, hemodialysis. Think about these different answers, and the correct answer is C, discontinuation of clarithromycin. Here on the right we have a picture of foxglove. This is the plant you get digoxin from. So observation alone is not appropriate. You have to discontinue what caused the elevation in digoxin level, and it is clarithromycin, so you have to stop that. Digibinds is inappropriate because we don't have arrhythmias, and hemodialysis is not beneficial because digoxin is not dialysable. So what about clarithromycin and digoxin? Clarithromycin increases digoxin half-life by up to 80%, okay? The level can increase by up to 70%. It inhibits the P-glycoprotein-mediated efflux of digoxin from the cells. Okay, so digoxin stays in the cells and causes toxicity. Other macrolide antibiotics like erythromycin and azithromycin should be avoided with digoxin. Okay, now we're not going to use digoxin-specific antibody fragments or digibind because we don't have life-threatening arrhythmias, the level is below 4, we don't have acute kidney injury, we don't have altered mental status or hyperkalemia. Okay, now if you get a question and there's clarithromycin in the answer, it's always going to be clarithromycin. This medicine interacts with so many medications, 683 drugs according to drugs.com. There's no way you can memorize that. So here's what I memorize. I don't use clarithromycin unless there is a very strong indication. Okay, and of these interactions, we have 269 major interactions. So this medicine is really problematic, and we should avoid using it unless there is a strong indication. Okay, so this is what we've learned now about clarithromycin, and now we'll move to question number 5. Here we have a 25-year-old woman. She's gravida 1, para 0. She's in her 3rd week of gestation. The patient has chronic high blood pressure and a known history of end-stage renal disease secondary to focal segmental glomerulosclerosis. The patient received a kidney transplant from her mother 2 years ago. She is on mycophenolate mofetil, MMF or Celcept, tacrolimus, also known as Prograf, and prednisone. She takes lisinopril for her high blood pressure. On exam, blood pressure was controlled 128/72, heart rate 81. Her hemoglobin is 11.1, creatinine is in the normal range 0.9, BUN 22, estimated GFR is 91. Potassium is normal 4.7, serum CO2 is normal at 24, urine albumin creatinine ratio is 22 milligram per gram, normal less than 30, so that's also normal. What is the next step in her management? A, discontinue lisinopril and start nifedipine for her high blood pressure. B, discontinue lisinopril and mycophenolate mofetil and start nifedipine for her high blood pressure and azathioprine as part of her transplant regimen. C. Discontinue lisinopril and tacrolimus and start nifedipine for high blood pressure and sirolimus for her anti-rejection regimen. Or is it D. Discontinue mycophenolate mofetil and prednisone and start losartan losartan for further blood pressure management and everolimus to replace both the prednisone and the mycophenolate mofetil for her transplant. So think about these different options, and the correct answer will be on the next slide. The correct answer is B. Discontinue lisinopril and mycophenolate mofetil and start nifedipine and azathioprine. So let's dissect that. This patient has chronic high blood pressure. She needs an agent for blood pressure control. In pregnancy, it's simple. We start with nifedipine. If that's not enough, we add labetalol. If that's not enough, we add hydralazine. Alpha-methyl-dopa is hard to find and has many side effects. So remember nifedipine, labetalol, and hydralazine. Diuretics, usually we don't start them. If the patient is already on a diuretic, we can continue that. We can start diuretics if they are really needed. Okay, so lisinopril, ACEs, and ARBs are absolutely contraindicated in pregnancy and should be discontinued as soon as pregnancy is diagnosed. Why? Because they cause malformations. They can cause malformation in the fetus, especially urological malformation. So lisinopril is definitely out. Losartan doesn't make any sense because it's an ARB. So ACEs and ARBs are absolutely contraindicated in pregnancy, especially after the first trimester. But you should stop them as soon as possible. Now, mycophenolate mofetil is also absolutely contraindicated in pregnancy and should be stopped as soon as pregnancy is diagnosed. As a matter of fact, patients who are on mycophenolate mofetil, who are contemplating a pregnancy, we stop the mycophenolate and we put them on azathioprine, which is safe in pregnancy, before conception. Okay, so that's why the correct answer is you stop lisinopril, you start nifedipine, you stop mycophenolate mofetil, and you start azathioprine. So option A is not enough. Yes, you stop lisinopril and start nifedipine, but you did not address the mycophenolate. Option C doesn't make any sense because tacrolimus is safe in pregnancy. Why do you want to stop it? And option D makes less sense because prednisone is safe. You just want to stop the mycophenolate and the lisinopril. Losartan is just as bad as lisinopril, and you don't want to use everolimus. We don't have much information about that. So this is a good question. You learn about what's safe and what's not in pregnancy. Let's move on now to question number 6. A 75-year-old woman presents to the emergency department with palpitations, dizziness, and near syncope. She has stage 3 chronic kidney disease due to hypertensive nephrosclerosis. Her past medical history is significant for heart failure with reduced ejection fraction. She's on the following medications: lisinopril, atorvastatin, aspirin 81 milligrams a day, and fluconazole that was started 2 days ago for oropharyngeal candidiasis. 3 days prior to her presentation, she started on her own an oral antibiotic for recurrent sinus congestion. Now, on exam, blood pressure was 88/42, heart rate was 102, the rhythm was irregular, an ECG was obtained right away, and you can see the picture below. Take a second to look at that. What antibiotic is the likely culprit? Is it azithromycin? Is it B, doxycycline? Is it C, erythromycin? Or is it D, cephalexin? So think about these different answers, and the correct answer is option C, erythromycin. Now, erythromycin and fluconazole have a known drug interaction, and this combination actually is contraindicated. Why? Because you're going to have a prolongation of QT interval, okay, and you're going to have arrhythmias. Now, you probably all know what we saw on the ECG. It's torsade de pointe, and so you had the fluconazole, and then you had the erythromycin, and that prolonged the QT interval, and then you have this abnormal and potentially life-threatening rhythm. Now, this does not happen if you use azithromycin, doxycycline, or cephalexin with fluconazole. Now, so like when we talked about clarithromycin, where we have many drug-drug interactions, fluconazole is another medicine to watch, okay? So be careful if you put anyone on fluconazole. Really invest in a good app for drug-drug interactions. Now, question 7. So erythromycin and fluconazole were discontinued in this patient. Now, what do we do next? A, give IV magnesium sulfate. B, IV calcium gluconate. C, IV potassium phosphate. Or is it D, obtain baseline chemistry profile first, and then you decide what you want to give. So please think about these different options, and the correct answer is on the next slide. So obviously it's IV magnesium sulfate. I trust that you all know the treatment of torsade de pointe. If the patient has no pulse, they're unstable, you're going to defibrillate them. Okay, so you treat that like you would ventricular tachycardia. You still give the intravenous magnesium sulfate. Now let's move on. Question number 8. A 55-year-old man presents with a gout flare. He has chronic hypertension, peptic ulcer disease, history of end-stage renal disease secondary to IgA nephropathy. This patient received a deceased donor kidney transplant at age 25. He's had his transplant for 30 years. He is on cyclosporin, azathioprine, prednisone, pantoprazole, and lisinopril. Labs, hemoglobin 11.5, creatinine 1.4, BUN 29, estimated GFR is 59, potassium 4.7, serum CO2 is normal at 24, uric acid is elevated at 7.9 milligram per deciliter, urine albumin creatinine ratio is 49 milligram per deciliter, normal is up to 30. What is the best option for his management? A, so obviously this patient has gout, okay? A, give colchicine 1.2 milligram once, and then 0.1 milligram 1 hour later, and then 0.1 milligram daily for maintenance. B, increase prednisone from 5 milligrams, his current dose, to 50 milligrams daily, and then taper over 7 to 10 days. C, add allopurinol. You've seen his uric acid 7.9. Add allopurinol 300 milligrams daily. Or is it option D, give indomethacin, very known non-steroidal anti-inflammatory medication, 50 milligrams 3 times daily. So think about these different options, and the correct answer is on the next slide. The correct answer is B, increase prednisone to 50 milligrams daily, then taper over 7 to 10 days. Why is that? Well, this patient is status post-kidney transplant, and he is on cyclosporin, okay? Someone is on cyclosporin, you don't give them colchicine, because then the half-life of cyclosporin is going to be increased, the colchicine half-life is going to be increased, and you are going to have colchicine toxicity. So this patient can have muscular problems, neurological toxicity, GI toxicity. If you're ever going to use colchicine, you have to follow cyclosporin level, you have to reduce the dose, and definitely you're not going to use 1.2 milligram followed by 0.6. Probably I would use 0.3 to 0.6 milligram daily. But preferably, we should not use colchicine at all in combination with cyclosporin. So remember, colchicine, cyclosporin, drug-drug interaction. Now, B is a good option because it's a good treatment for gout. Allopurinol is really inappropriate for an acute gout attack. It can make it worse. This may be something after you treat the acute gout flare. So definitely you don't give allopurinol. If the patient is already on it, you keep them on it. But and allopurinol is also a medicine that has many issues and drug interactions. Indomethacin, don't tell any nephrologist about this option. I mean, this is a kidney transplant patient, and he has peptic ulcer disease. You're going to use a whopping dose of indomethacin, 50 milligrams, 3 times a day. Yeah, his gout will get better, but you could end up with peptic ulcer bleeding and acute kidney injury. So please don't do that. Now, moving on. Cyclosporin, colchicine interaction. Remember that both elevate each other's level, and you increase the risk of side effects, including muscle problems, nervous system problems, worsening of kidney and liver function. So let's remember this drug interaction. Question 9. A 65-year-old man presents with sepsis of a urinary tract origin. He has chronic hypertension, benign prostate hypertrophy, and a history of chronic heart failure with preserved ejection fraction. He is on tamsulosin, amlodipine, and lisinopril. On exam, blood pressure 88/32, heart rate is 121. Labs, hemoglobin 10.5, creatinine 1.7, BUN 59. CKD epi equation, estimated GFR is 44, so this puts him as stage 3B chronic kidney disease. Potassium 4.9, CO2 is depressed at 19, uric acid is elevated at 7.9. So this patient is septic. We're good physicians, so we are starting the patient on an antibiotic as soon as possible, piperacillin tazobactam, okay, because of sepsis. And we are resuscitating this patient with 3 liters of lactated ringer, but the patient remains hypotensive despite resuscitation. What are we going to do for his sepsis to bring his blood pressure up? A, start intravenous albumin 25 grams intravenously every 6 hours. B, start dopamine at 2 microgram per kilogram per minute, or renal dose dopamine. C, start the patient on norepinephrine drip. Or is it D, start the patient on intravenous hetastarch? So think about these different options, and the correct answer is norepinephrine drip, option C. Now, albumin is not a bad option, but you already gave 3 liters of lactated ringer. In this patient, there's no advantage of colloids versus crystalloids, so it's not a bad option, but it's not the best option. According to all guidelines, you have to go to norepinephrine. Dopamine is not a good answer. First, renal dose dopamine, there's no evidence whatsoever that it helps the kidneys. Yes, it dilates the renal artery. This is so 30 years ago. Okay, so that's done. It's been debunked. So don't use renal dose dopamine. It will raise blood pressure. It will cause tachyarrhythmias, can cause atrial fibrillation. I've seen it used by cardiologists for similar situations if the patient is bradycardic, actually, to raise their heart rate. Generally speaking, you don't want to use dopamine. You want to use norepinephrine first, and then vasopressin, and then everything else. So fluids, norepinephrine, vasopressin, corticosteroids, then everything else. Hetastarch should not be used in this patient. I don't think it should be used in any patient, because it increases the risk of acute kidney injury. Here we already have someone with creatinine 1.7, stage 3B chronic kidney disease. So don't use hetastarch. It's expensive, and I don't think it's widely available. So the correct answer is definitely C, norepinephrine drip. Now, let's move on to the last question. Question number 10. A 62-year-old man presents to the renal clinic for a routine follow-up. He has stage 4 chronic kidney disease secondary to diabetic nephropathy. He has history of chronic hypertension, hemoglobin 10.8, creatinine 2.7, BUN 52. CKD epi equation shows estimated GFR of 26. Potassium is elevated at 5.5. Serum CO2 is 22. Urine albumin creatinine ratio is elevated, 455 milligram per gram. Normal is less than 30. He is on insulin glargine, so he is on Lantus already, sitagliptin, lisinopril 40 milligrams a day, and amlodipine 5 milligrams daily. Blood pressure is controlled 127/78. Now, what are we going to do next for his management? So we have someone with chronic kidney disease stage 4, diabetic nephropathy. Blood pressure is controlled, but he continues to have significant albuminuria. Option A, increase lisinopril to 80 milligrams per day. Option B, add losartan 100 milligrams a day to lisinopril. Option C, add spironolactone 25 milligrams a day and losartan 100 milligrams a day to his lisinopril. Option D, start a potassium binder, okay, such as sodium zirconium, cyclosilicate, or paturimer, and add dapagliflozin or Farxiga. So think about these different options, and the correct answer is, so the answer is D, start a potassium binder and dapagliflozin. So why is that? Now, the first answer, increasing lisinopril to 80 milligrams, what this is going to do is going to worsen the hyperkalemia, and you're not going to get much improvement in her proteinuria. Now, adding losartan is contraindicated. If you combine an ACE and an ARB, you're going to get more hyperkalemia and acute kidney injury. So that's not acceptable. If you add an ARB to an ACE and you add spironolactone, you're probably going to get severe life-threatening hyperkalemia. So that's not appropriate. Potassium is already high. So what we're going to do, the patient needs to be counseled on a low potassium diet. We're going to start a potassium binder, such as sodium zirconium cyclosilicate or paturimer, one of those new binders, to get the potassium down so we can continue the lisinopril, because we need that to reduce the proteinuria. And we're going to add dapagliflozin. Dapagliflozin is very helpful. And to start, at least for now, you need estimated GFR 25 or above. So we're almost just there. Okay, if it drops much further, we won't be able to do it. So we'll add dapagliflozin. Okay, so this concludes this session. Please tell me what you thought in the comment section. What other areas of internal medicine you want to hear about or you want to discuss. Thank you very much, and see you in the next slide.